I think 2017 has been an amazing year for the changes in practice in non-small cell lung cancer, and I think it really ended with a bang, particularly with the improvement in progression-free survival in those patients with stage 3 disease who were treated with durvalumab after chemotherapy and radiation therapy. We have not yet seen an advance like that until now in 2017, and we hope over the next year or so we can see the improvement in overall survival as well. So I hope to see potentially an FDA approval over the next year for durvalumab in the consolidation setting. We will see. I certainly feel much more assured that we don't see a significant change in toxicity when we use this type of therapy after chemotherapy and radiation as well. So again, that's sort of just the tip of the iceberg. You know, certainly we've seen changes in metastatic disease when we're looking at immunotherapy. Now chemotherapy combinations are showing it an advantage compared to chemotherapy alone. But we're still all struggling yet looking at larger phase 3 studies. I think the most recent IEmpower data is very tantalizing. I'm not sure how much we use this in practice, adding bevacizumab with chemotherapy and now adding immunotherapy to it. I think you know, the progression-free survival data is very amazing, and I think trying to pick the right patients for these type of combinations will be very important. I think also if switching gears to patients with driver mutations, you know, the data from Flora showing bringing the best drug first line with osimertinib compared to Tarceva or Iressa in those patients with EGFR mutations. Certainly a much longer progression-free survival and disease control, particularly in those patients with CNS, is quite amazing, leading now to at least the compendia listing and FDA approval in the first-line treatment setting for osimertinib. And then also looking at the ALEX data, looking at alectinib versus crizotinib, again bringing, we think, one of the best drugs forward into the first-line treatment setting for those patients without disease. Again, better CNS control, longer progression-free survival as well. Again, amazing 2017. There's multitudes of options. Certainly, if they have high PD-L1, pembrolizumab as a single agent, in my mind, is still an option. Certainly, combining it with pemetrexed and carboplatin does increase the chance of response. So particularly in those patients where you need a good response in their tumors is very important. We'll see if the overall survival data continues to mature and show an advantage, though not statistically significant yet. Hopefully in the future we will see that those survival curves spread, as well as the phase 3 trials coming out showing the same thing. I think the IEmpower data gives us a little bit more data to think about combining chemotherapy, bevacizumab plus immunotherapy. Again, now a 4-drug regimen. You know, we'll be very happy when all these things go off patent, so it won't be so expensive, certainly, but I think showing a improvement in PFS is also very favorable. But I think also trying to figure out which patients really need that 4 drugs to get the longer disease control and improve survival. Again, time will tell and technology will tell. I think the over this past year now, ending with the IEmpower data showing an advantage of giving bevacizumab plus the standard paclitaxel carboplatin with atezolizumab, I think that's potentially reawakening the interest in using bevacizumab. I think we know that adding bevacizumab to chemotherapy improves overall survival, increases the response rate compared to chemotherapy, but certainly there's always toxicities that we get worried about, mainly bleeding and elevated blood pressure. But certainly adding atezolizumab from an immune standpoint, bevacizumab does have its immune effects and thus advantages of combining immunotherapy with that 3-drug combination. So pembrolizumab has been combined with pemetrexed and carboplatin mainly for the KEYNOTE-021G. We know that it increases response rate, increases progression-free survival. It's not yet significantly improving overall survival, but that data needs to continue to mature. But we have phase 3 studies coming, combining for non-squamous pemetrexed, carboplatin, or cisplatin with pembrolizumab versus the chemotherapy combination by itself, or also with paclitaxel carboplatin or Abraxane carboplatin as well. So we're looking at multiple different chemotherapy backbones for different histologies. Well, I think some of the overall survival data that we want to see from all the large first-line phase 3 trials, we hope to see some of that read out. Certainly the different chemotherapy combinations with immunotherapy, or even the IO-IO combinations compared to chemotherapy combinations in the first-line treatment setting. So I think over this next year, the first-line landscape might change significantly.